Hello, good evening, friends. Myself, Dr. Mukesh Kumar Seva, consultant urologist and head of department urology in Paras JK Hospital, Udaipur. I pursue my MBBS from SP Medical College, Bikaner, and MS from MPSA Medical College, Jamnagar, and MCS from Civil Hospital, BJ Medical College, Ahmedabad. Then I worked for 2 years with the Sterling Group, Ahmedabad, and then joined the Fortis Group in Udaipur. And at present, I am working in Paras JK Hospital, Udaipur, as a full-time consultant. So this is a very critical time, COVID era. We have to take care of ourselves as well as the general public, and we are in the healthcare. So we should be more vigilant and conscious regarding the COVID. We have to take care of public as well as ourselves with the proper precautions, social distancing, masking, frequent hand washing. So these are the common preventive measures that we have to take, all of us, to prevent the spread of the coronavirus. Along with that, corona is a different pandemic that has occurred after so many years and very critical time. But along with that, life is continuous and we are on routine work, most of the people. So as per that, today we are going to discuss a healthcare topic, that is the prostatic cancer. We will discuss about prostatic cancer because this is the second most common cancer in the men after the lung cancer. Lung cancer is the first cancer in men, and prostatic cancer is the second most common cancer and fifth most common cancer worldwide. If you are considering all the cancers, then this is the fifth most common cancer. So prevalence is very good. If you consider the incidence in the general public, then it is the 150 to 250 people per lakh of the population. This is the incidence of the prostatic cancer in general population. If you consider mortality rate, then 2 to 5% of total mortality because of the in cancers because of the prostatic cancer. So this is a very important topic for all of men that are having more than 50 years of age. So now we come to the topic with the basic questions. What is the prostate? What is the prostatic cancer? So prostate is a gland that gives the volume to the semen, and it liquefies the semen. Secretions of the prostate liquefy the semen. So it is a very important gland, and this is the man's gland. So this is the androgen dependent gland. In the body, prostate ability to respond to the androgen throughout the life. That means because of the androgenic effect, prostate grow continuously throughout the life from 20s to 80s and 90s. So when it grows, it gives obstruction to the urinary flow, and because of that obstruction, persons present with the symptom of frequency, urgency, hesitancy, poor stream, straining. These are the some symptoms that occur because of the prostatic enlargement. To these symptoms we call the lower urinary tract symptom LUTs. So now we will use the LUTs for the symptomatology. So this prostatic gland may grow in two types. One is the benign enlargement, or second may be the malignant form. Prostatic enlargement, that is the benign. For that, if a person having the LUTs and it is the obstructive type LUTs, then we do the endoscopic surgery like the TURP. But if prostatic gland is enlarged and it is the cancerous, then line of management and treatment differs from the benign enlargement. So now question comes, why these malignant changes occurs in the prostate? So there are a lot of epidemiological studies that show it is a multifactorial disease, and in multifactorial, the genetics is the most important factor that play important role. So in genetics, there are some genes that found in our genetic constitution, like the BRCA1, BRCA2, human prostatic cancer gene. So there are some infections like human papillomavirus, herpes simplex virus, HHV, 8, so cytomegalovirus, these viruses also have some role in the development of the prostatic cancer. Along with that, there is a insulin-like growth factor, smoking, obesity, some somatic mutation in our genetics, and most important is the androgen influence on the proliferation of the prostatic gland. So these genetics and these infective and multifactorial factors have the role in development of the prostatic cancer. So can we prevent this? No. The genetics and the environmental factors sometimes happens in our body that we cannot prevent. So it is not a preventable disease, but we can detect it earlier. We can detect earlier, and then in early stage we can do the proper treatment or proper surgery. In prostatic cancer, there is again along with the genetic predisposition, there is a hereditary also. If a father is having the prostatic cancer, then in son, there are 2 to 3-fold more chances of the prostatic cancer. If a brother is having the prostatic cancer, then in the siblings, there is a 3 to 4 times more chances of the prostatic cancer. If a person having the 2 first degree relative of the prostatic cancer, then he having the highest chances of the prostatic cancer, like the 5-fold increase of chances than a normal person. So there is a hereditary predisposition of the prostatic cancer in the family. So always be careful if your father, your brother, your second degree, your first degree relative having the prostatic cancer, then you should be more vigilant. You should go for the screening test of the PSA, so we can detect it early and we can do the proper treatment. So we have discussed about the incidence, family history. So what is the age? Most common age of occurrence of the prostatic cancer is the 7th decade, in between the 60 to 70. So this is the most common age of the presentation. And now if a person is having, how we can detect it or how we can screen it. So that is the important role. So there are some guidelines provided by the European Association of the Urology. If a person is more than 40 years and whenever or sometimes he has go for the prostatic screening, and if his PSA comes more than 1, or a patient is of 60 years and he has went for the health checkup and PSA comes to the 2, so these 2 patients, more than 1 PSA at 40 years and more than 2 PSA at 60 years, these are the high risk group. So these people should be go for the screening. If you are high risk group, then you have to go for the every second year for the PSA screening. So what is the PSA? So PSA is the hormone that is secreted from the prostatic gland. This is the secretion of the prostatic gland, and it secreted from the prostatic cells. It comes to the blood, and we can detect it from the blood. So full form of PSA is the prostatic specific antigen. So if PSA is high, then it may because of the 2 conditions. One is the severe prostatic infection that called the prostatitis, and second is the prostatic malignancy. So how we can rule it out? If it is because of the prostatic infection or prostatitis, then we treat patient with the antibiotics, anti-inflammatories for a few days, and then PSA will come down. And if it decreases by the 50%, then we can say it was because of the infection and there is no chance of the malignancy, and we follow this patient for up to 3 months. We give antibiotic for the 3 months, and if PSA comes within the normal limits, then it's okay. If patient comes with the high PSA and we suspected the infection, we give the antibiotic, but still PSA not reduced by the 50% in 2 weeks and not reduced up to the base level like the less than 2.5, then we should suspect about the prostatic cancer. So how to screen and what is the criteria for screening? So this is the basic. There is one important thing we have to know. There is no clear-cut margin or threshold of say PSA level. That means if someone is having the PSA 2, he may also have prostate cancer. If PSA having 10, then he may also have the prostate cancer. So that is the clinical judgment when we have to go for the biopsy and when we have to suspect about the malignancy. So ultimately there is no clear-cut threshold of cutoff value for the PSA that we can rule out the prostatic cancer. Second, so if there is a we are suspecting prostatic cancer in USA and European society, there are some screening protocols and for early detection of the prostatic cancer. But in India, still there is no clear-cut guidelines for the PSA screening. But we are following the European and American protocols for most of the disease. So again, in prostatic PSA screening, we also use the same protocols. So when you should go for the PSA screening? When your age is more than 50 years, and if any of your family members, first degree or second degree relative, having the prostatic cancer, then you go for the screening at age of 45. So these are two basic criteria for the prostate PSA screening: for 50 years in the normal person and 45 years for a person having the hereditary history or history of the family member that having the prostatic cancer. So these two are the screening methods. Now, if you have go for the screening method and your PSA comes high, then what is the next? So as earlier we have discussed in the same talk, two causes of the high PSA. One is the severe prostatic infection, second the malignancy. For if you are suspecting the prostatitis, then we have to give the antibiotic. PSA will reduce up to 50%. Again, we will give the antibiotic, and we can continue these antibiotics and anti-inflammatory up to 3 months. If within the 3 months we come to the nadir level of the PSA, like within normal limits of 2.5, then it's okay. If it doesn't come to the normal level, like the 2.5, less than 2.5, then we have to think for the prostatic biopsy. So what is the biopsy? To confirm the prostatic malignancy, if PSA is high and we are suspecting the prostatic malignancy, then there are two methods. One, we can go for the some radiological investigations like multiparametric MRI, that is also 98% sensitivity, and second is the prostatic biopsy. But if you are going for the multiparametric MRI, then again we have to go for the histopathological diagnosis of the malignancy. So ultimately we have to do the prostatic biopsy. Prostatic biopsy is a very simple and day-care procedure. If PSA is high, we have planned for the prostatic biopsy, then we do the prostatic biopsy under local anesthesia or periprostatic block. In that we give patient to the left lateral position, and with the 18 gauge small needle, we do the prostatic biopsy transrectally. And in this method, we took 12 to 14 cores. Cores means bite. So we took 12 to 14 core from right and left both lobes, and we send these tissues for the histopathological examinations. And if the biopsy comes to be the benign enlargement, then patient having obstructive symptom or obstructive LUTs, then we can do the TARP as a endoscopic surgery. And if it comes to be the positive, then we have to go for the definitive management of the prostatic cancer. So what is the treatment for the prostatic cancer? So answer to this question depends on the stage of the prostatic cancer. No, what is the stage? Stage generally for the cancer, in layman language you can say there are multiple stages like stage 1, 2, 3, 4. So every tumor, for the every cancer in the body, we are having some classification or some common terminology So everyone in the universe is following that terminology. Then person sitting in the US, if you are giving him the staging of the prostate cancer in the TNM staging like tumor node and metastasis, then he can understand you what is the disease progression, how much is the load in the body, in lymph nodes, in bony mats or visceral mats or all that. So this is the staging of tumor. So for that, in prostatic malignancy, we do the multiparametric MRI. So that gives us idea about the local spread of the tumor, and sometimes we do the CT scan to know the lymphatic metastasis. Now, in recent times, there are one more test that is available, that is the PSMA PET scan, prostate specific membrane antigen PET scan. So that is the specific for the prostate, and with the PSMA PET scan, if we are going upfront PSMA PET scan, then we can know the local spread of the disease as well as the lymphatic spread or the bony spread of the prostate. If we have to do the biopsy, if we have to do the multiparametric MRI, and if we have to do the PSMA PET, but PSMA PET is a little bit costlier test, and we can avoid in the initial screening method or initial diagnostic tool. So initial diagnostic tool are the laboratory investigation, PSA, digital rectal examination for clinical assessment, then multiparametric MRI to know the local spread of the disease. And now there are some basic parameters. So this prostatic cancer is the low risk, intermediate risk, or high risk. So what is the risk? Risk is the, again, this is the staging of the prostatic cancer. If prostatic cancer in tumor stage is like T1, T2, with the PSA is less than 10, and if in biopsy Gleason score comes less than 7, then this is the low risk disease. If PSA is in between 10 to 20, Gleason score is 7. So this will be considered as the intermediate stage. Now, if the PSA is more than 20, Gleason is more than 7, and T3B disease, so then it will be the intermediate high risk. Sorry, T3. So these are the some staging method. We divide this malignancy in the low risk, intermediate risk, and high risk. These all are the localized. These are classification for the localized disease. Second is the locally advanced disease. If this prostatic cancer invading the bladder neck, rectum, external sphincter, then this is a locally advanced disease. So for locally advanced, there is no low, intermediate, high risk group, but for the locally advanced, so locally limited disease, low, intermediate, high risk. So for the locally advanced disease, treatment protocol is different, but localized disease, low risk, intermediate risk, or high risk group, in this management will be the different. So for the low risk group, we are having 2 to 3 options of management. Like we can go for the active surveillance of the patient, then a watchful waiting, then radical prostatectomy, there is a radiotherapy. These are the method of treatment for the localized disease. So in localized disease, in intermediate group, again there is a treatment tools are the radical prostatectomy, that is the open surgery, or we can do the laparoscopic radical prostatectomy or robotic radical prostatectomy. We can go for the radiotherapy, that is the CRT, conformal radiotherapy, and intensified IMRT radiotherapy. So these are the methods of the radiotherapy. Again, if prostatic cancer is a locally advanced, that is the T4, we can say this is the 4th stage of the cancer. Generally, for the T, N for lymph nodes and M for metastasis. These 3 factors in the TNM staging or staging. So if there is a metastasis and there is a lymph node positive, then all three comes in locally advanced or metastatic disease. So in metastatic and locally advanced disease, again, if it is not distant metastasis, only it is the lymph node metastasis, then again we are having option radical prostate and radiotherapy after the hormonal treatment. But if it bony metastasis, then androgen deprivation, removal of the testes or surgical or medical castration or androgen deprivation is the primary line of treatment. So what is this hormonal or the surgical or medical castration? In this, if the prostatic cancer that is the in fourth stage, then we do the for understanding of this management, we have to go for the some physiological understanding of the prostate. So earlier, as we discussed, prostate is the androgen dependent proliferation. Androgen is the testosterone hormone that convert to the dihydrotestosterone, and dihydrotestosterone give the stimulus to the prostatic gland for the proliferation. So this is the continuous stimulation, and it help in the growth of the prostatic stromal cells. So if we will inhibit this androgen stimulus, then prostatic gland will not grow. It will inhibit the growth of the prostatic gland. So if disease is the locally advanced or metastatic, then there is no role of the curative surgery like radical prostate or curative radiotherapy. We have to go for the palliative management. Palliative management means जो कि पेशेंट को पेन फ्री रखे और उसको डिजीज के प्रोग्रेशन को स्लोअर करे, बट डिजीज को क्योर नहीं करे. सो फॉर द पैलिएटिव मैनेजमेंट वी डू द androgen deprivation, like androgens are giving the stimulus to prostate for growth. So if we will remove this androgen support, then prostatic growth will be inhibited. So how we can do the androgen deprivation? Androgen deprivation we can do by two methods, either it is medical or surgical. In surgical, bilateral orchidectomy, that means removal of the testes, is the method of surgical method of the androgen deprivation, and that is the surgical castration. Second option for the androgen deprivation is the medical castration. So what is the medical castration? So in this we give some injection to the patient that inhibit the androgen production, and if it will inhibit the androgen production from the pituitary gland, so androgen level will be low in the blood, and that will inhibit the prostatic growth. So there are two methods of androgen deprivation. One is the surgical castration, one is the medical castration. So by these two, we can prevent the prostatic growth, and we can reduce the growth of prostatic proliferation and growth of the tumor. If this locally advanced or metastatic prostatic cancer having the multiple bone metastasis in bones and lymph nodes and patient having symptomatic, then what options we are having? Again, with the hormonal treatment available in the present era, and these hormonal treatment are based on in the form of the tablets like the abiraterone or enzalutamide. These are the two tablet forms of hormonal treatment for the metastatic castrate resistance. That means there are metastatic prostatic cancer. We have given either surgical castration or medical castration option. Even though PSA is rising or prostatic cancer is spreading or patient having symptom, then we can give the abiraterone or enzalutamide to that patient. So this is the basic concept along this metastatic prostatic cancer having effect on the bones. So to these patients we are giving some calcium supplement, some vitamin D supplement, or zoledronic acid or denosumab. These are the some osteoprotective or bony protective medicines that we have to start to these patients. So this was a brief knowledge that I have provided about the prostatic cancer in the general public. Now we are having some questions from the audience. So someone has asked about the PSA screening. So earlier I have told there are two methods of screening. One is the blood test and second is the clinical examination. So clinical examination, your clinician can judge the prostatic gland is hard or soft. And second screening is the PSA screening. In PSA screening, when you have to go, if you are more than 50 years, then you have to go for the PSA screening. If you are first degree or second degree relative having the history of the prostatic malignancy, then after the age of 45, you have to go for the PSA screening. So this is a PSA screening method in the general public. So second question is the one audience have asked about the simple prostatic enlargement and the cancerous, how we can differentiate. Again, I have told in the talk, we do the clinical examination, we do the PSA. If PSA is high, like more than 2.5, then we are suspicious about the prostatic cancer, and to rule it out, we do the multiparametric MRI or prostatic biopsy. If PSA is low, less than 2.5, then there is a very few or less chances of the prostatic malignancy. But one thing should be clear in mind: there is no absolute cutoff PSA level that can rule out prostatic malignancy. Less than 2.5 PSA, there are always chances of prostatic malignancy. But these are the some indolent and hidden malignancies. So if you are doing biopsy in the less than 2.5, then we are getting the 15% of population that having the some element of the prostatic malignancy. But that will be the indolent, like the if glycemic score is 6 or less, then we are telling it is a clinically insignificant malignancy, and we can go for the watchful waiting or active surveillance in if a glycemic score is less than 6. So again, if pH is less than 2.5, in that case also there may be the prostatic malignancy, but chance is less as compared to the pH is high. One patient asked about the multiparametric MRI. So this is a clinical, this is a radiological test, and it is also sensitive. If in recent era we are getting PSA high, then with the help of the MRI we can identify or we can detect the prostatic cancer nodules. Right, like in the prostate there are two right and left lobes. So where is the nodule and where is the high chances of the prostatic cancer? So that multiparametric MRI can tell us, and we can take the targeted biopsy from that region. So this is a diagnostic tool and very important and very useful tool in recent era. So thank you to all listeners for this topic. Thank you again.